Welcome to Module 2, Components of an Effective Pain Treatment Plan, Goals, and Non-Pharmacological Strategies. My name is Laura Meyer-Junco, and I'm a clinical assistant professor at the University of Illinois Chicago College of Pharmacy in practice as a clinical pharmacist in hospice, palliative care, and geriatrics in Rockford, Illinois. I serve as the editor-in-chief of the Journal of Pain and Palliative Care Pharmacotherapy and facilitate a free 6-week online pain self-management workshop called Healthy Living with Chronic Pain. I have nothing to disclose. The learning objectives for this module include: describe the components of a pain treatment plan, including non-pharmacological approaches. And today we are going to stratify those approaches into 3 buckets: restorative therapies, behavioral therapies, and complementary and integrative health modalities. And our second learning objective is we're going to identify the goals of treatment as it relates to both pain and function. Before we discuss the components of a treatment plan, we need to talk about the components that make up total pain. Pain is a complex experience that incorporates many dimensions and often goes beyond just physical pain. It can include psychological pain, existential pain, such as what is the meaning of their life, what is their purpose, as well as spiritual pain. Therefore, our comprehensive care plan for many patients may need to incorporate these other dimensions. And we'll talk about today use of non-pharmacological therapies that may address these other components of total pain and go beyond just the physical dimension. Given the complexity of the pain experience and the interplay between the various components of total pain that contribute to the pain experience, the National Pain Strategy recommends a biopsychosocial approach to pain care. So this means our approach to pain treatment should involve not just strategies that address the physical domain or biology, but also address psychological and social concerns that affect individuals and their pain experience. And this approach should be grounded in scientific evidence, integrated, multimodal, and interdisciplinary, and most importantly, tailored to that individual patient in front of us. In the biopsychosocial model of pain, there are many factors that contribute to the way patients perceive and cope with their pain. There could be biological factors, so the injury, the anatomy of the patient, the illness itself, as well as psychological factors. What is the meaning of their pain? Perhaps they have comorbid anxiety and depression and stress, and that can enhance and worsen the pain experience. Or maybe cultural background or other social factors, such as lack of social support or economic stressors, can worsen the pain experience for individual patients. And so in the biopsychosocial model, all of the factors that may influence our individual's pain experience should be evaluated and addressed. While helpful in acute pain, the biopsychosocial approach to pain is critical in chronic pain. By definition, chronic pain is pain that continues past the usual time for healing. In contrast to acute pain, it has no survival value. While tissue is the issue in acute pain, tissue may no longer be the main issue in many forms of chronic pain, particularly nociplastic pain. Treatments for chronic pain are often ineffective, and this could be due to a narrow focus on the physical dimension, the anatomical structures, and the pathophysiology. But chronic pain and the persistence of pain could be this complex biopsychosocial phenomenon that interferes with many aspects of a patient's life. So the treatment needs to focus not only on the physical dimension, but also on the psychological and the social dimension. So in acute pain, the role of our providers are to diagnose and to treat and use multimodal therapy, where in chronic pain, it is important also to engage the patient as an active member of their pain treatment. And so in this module, we'll discuss pain self-management, which is a form of education and non-pharmacological approach that puts the patient in the driver's seat so that they become an active pain self-manager. So the role of the patient in chronic pain is important. They need to drive their care. In order for our patients to be active self-managers of their chronic pain and buy in to a comprehensive care plan based on the biopsychosocial model for pain, our patients need to have education, particularly pain neuroscience education and understand the role of the brain in pain. Our understanding of the brain's ability to change its own circuitry is increasing. This is known as neuroplasticity, the capacity of neurons to change their structure, their function, or even their chemical profile. Chronic pain may be the consequence of these plastic changes in cortical limbic circuitry, leading to new learning and to memory formation that are continuously enforced. So if chronic pain could at least partially be a persistent memory of pain, then the treatment should include psychological approaches in addition to pharmacological and physical approaches. The central nervous system and the brain are plastic. Essentially, they change and adapt to new information all the time. But this is good news. This means that patients can influence their nervous system and their brains and retrain over time using some of the non-pharmacological mechanisms that we're going to discuss in this module. The influence of cognition and emotion on pain is also pretty remarkable. Clinical and experimental studies have shown this. For instance, in one study, negative treatment expectation interfered with the analgesic potential of remifentanil, a potent analgesic, to the extent that its effect was completely abolished. A number of reports have shown that pain is perceived as less intense when individuals are distracted from their pain. And separate from the whole business of attention and distraction, our emotional state has also shown to have an enormous influence on pain, as a negative emotional state increases pain, where a positive state lowers pain. Cognitive and emotional factors have an important influence on pain perception. Although we do not have all the answers, we do know that multiple pain pathways in the central nervous system are involved in pain processing. Several brain areas are activated by noxious stimuli, including the primary and secondary somatosensory cortex, which encodes the sensory features of pain, its duration and location. It is thought that when patients have increased attention to their pain, S1 activity is higher. Now, this noxious stimuli also reaches components of the limbic or emotional part of the brain, so the ACC and the insular cortex. With negative emotional states, activity in the ACC is stronger. Now, this information also interacts with the prefrontal cortex, where we would associate meaning to this noxious stimuli. So there is some thought that in chronic pain, there could be some limbic cortical plasticity in which learning and memory can lead to the persistence of chronic pain, among perhaps other things as well. An important part of pain processing is the descending pain modulation pathway, which descends from the brain to the spinal cord and has inhibitory actions on signals in the spinal cord, making the way to the brain. The descending pain pathway has projections from the PNG, which interact with areas of the brain involved in the emotions and the limbic portions of the brain. This suggests that descending modulation can be highly influenced or even diminished by psychological factors. To effectively engage a patient in all components of a biopsychosocial model for pain, education is needed. Pain neuroscience education aims to help patients understand the role of the brain in pain, and using metaphors and analogies, it often helps to reframe for patients that pain is damage, and instead, that pain is a perception. The brain is the command center of the nervous system, and it has the final say on whether we experience pain. And it relies on three pieces of information: our body sensations, our thoughts, and our emotions. If we have negative thoughts or emotions or are catastrophizing or are simply just afraid of our pain, the brain has to review all of this information and can interpret our physical sensations, our body sensations, as danger. So essentially, our thoughts, emotions, and negative expectations for our future can cause the brain to sound the danger alarm and ramp up our body sensations and increases the amount of pain we feel. What I just shared with you is an example of pain neuroscience education that is used to educate patients about the biopsychosocial model of pain and also give them a greater sense of control over the aspects of their pain that they can control, such as their thoughts and emotions that feed into the neural matrix in the brain in addition to body sensations. If they engage in activities like cognitive behavioral therapy or pain self-management and other behavioral therapies, they may be able to reconstruct their relationship with their pain, which may signal less danger from the brain's neural matrix and therefore less pain. To fully understand a patient's pain experience, we must understand the patient's thoughts and beliefs about their pain and recognize the impact that these negative thoughts, emotions, and worst-case predictions have on their lives. However, it is important to recognize that we as clinicians must always validate patients' pain experience, and the biopsychosocial model is not to imply that their pain is self-chosen or all in their heads. One thing to recognize is that in pain, it's not always mind over matter, but the mind does matter in chronic pain. Pain neuroscience education in of itself is an important intervention and has been described in the literature to be associated with improved patient-reported pain scores, as well as improved mobility, reduced catastrophizing, and even in some cases, reduced healthcare utilization. But what is more important is that education, such as pain neuroscience education, may increase patients' willingness to engage in behavioral therapies such as cognitive behavioral therapy and programs such as pain self-management. Pain self-management programs are highlighted in the National Pain Strategy as programs that help to strengthen patients' skills and confidence through education and explanation of the biopsychosocial model, as well as regular discussions and assessment of techniques for dealing with pain, including stress reduction techniques, planning and pacing, communicating with healthcare providers, and also the skills to continue a normal life despite their pain and to deal with the consequences that come with pain, such as the negative emotions and negative thoughts. Now, these programs can stand alone or can be individually directed or integrated into healthcare settings. So pain self-management is becoming more of a prominent discussion in current chronic pain guidelines, which I will show you later when we discuss chronic musculoskeletal pain guidelines. It is important to recognize that chronic pain is associated with other symptoms as a result of living with pain. So we talked about that chronic pain can contribute to difficult emotions and negative thoughts, but it also can lead to poor sleep, fatigue, inactivity, and functional limitations. And so it's important that our therapies for pain are multimodal and address these other symptoms that are associated with chronic pain, such as poor sleep and inactivity. The Pain Management Best Practices Task Force was convened by the U.S. Department of Health and Human Services, and in their 2019 report outlined components of a comprehensive treatment plan, which should be individualized, multimodal, and multidisciplinary, and use one or more treatment modalities as clinically indicated. These treatment modalities are divided into 5 broad categories: medication, restorative therapies, interventional procedures, behavioral health approaches, and complementary and integrative health. We will talk about today non-pharmacological therapies that fall in the 3 categories of restorative therapies, behavioral health approaches, and complementary and integrative health. What is important to recognize that in our treatment plans, what is ongoing is risk assessment of our patients, as well as addressing and reducing stigma and improving access to care. And importantly, as previously shared, education is going to be a cornerstone part of our comprehensive treatment plan. Prior to delivering the treatment plan, patients should have sufficient education, and this education should include education about the painful condition and what to expect. Education should also include pain neuroscience education that emphasizes the biopsychosocial model for pain. Patients should also be educated on how to take an active role in their pain management, aka self-management. Patients should also be educated on what to expect from treatments, negative and positive expectations, as well as the treatment goals, and how their management is going to be guided by symptoms and physical function and social functioning, etc. And managing patient expectations. How much is this individual intervention going to reduce pain, and what should they expect? and treatment agreements could be a potentially useful tool to deliver some of this educational material. In their second recommendation in the CDC's Clinical Practice Guideline for Prescribing Opioids for Pain in 2022, authors recommend that before starting opioid therapy for subacute or chronic pain, clinicians should discuss with patients the realistic benefits and known risks of opioid therapy, should work with patients to establish treatment goals for pain and function, and should consider how opioid therapy will be discontinued if benefits do not outweigh risks. In this module, we are talking about non-pharmacological therapies, and I would extend this statement from the CDC to all therapies that are initiated or discussed with patients, that before delving into a treatment option, the patient is well-versed on the relative benefits and risks of that therapy, as well as what the treatment goals are for this individual therapy, and to ensure they are aware of all of the options available. For patients with chronic pain, there should be an ongoing discussion of risks versus benefits of treatments. There should be evaluation of patient risks, as well as ongoing education and reassurance and ensuring that the patient is actively engaging in his or her pain care. And part of this is also managing patient expectations and help them to recognize that current pain treatments do not eliminate pain, and trying to do so could be dangerous, but may result in a 30% reduction in pain. If you even look at how clinical trials of analgesics are designed, the outcome is a 30 to 50% reduction in pain. So having a 30% reduction in pain can have a meaningful impact and improvement in function and quality of life, which is ultimately the objective goal that we are focused on, improving patients' function and engagement and meaning and having a meaningful life. And want to educate patients that reducing pain to zero is not a reasonable expectation, but reducing pain to a tolerable level that allows them to engage and function in their lives. It's also important to educate patients that hurt does not always equal harm, and to reassure them that they can engage in gradual increases in activity safely. Given our understanding of a biopsychosocial model for chronic pain, focusing only on the intensity of pain is inadequate. Our initial evaluations and ongoing evaluations of patients should assess biopsychosocial factors that underlie their pain. And our treatment goals should go beyond assessment only of pain severity and intensity, and also incorporate functional goals. And these functional goals should be decided on with the patient prior to initiation of that treatment. And patients should be involved in the discussion of setting these functional goals. And these functional goals should have meaning for them, such as maybe walking the dog, attending family events, or returning to work. So as you can see, functional goals are not just in the physical sense. Functional goals can also be in the emotional sense, including a reduction in fear of movement, or reduction in fear of catastrophizing, as well as improvement in social functioning, such as attending family events. Now, our specific goals need to be tailored to our individual patients. So if patients have progressive functional limitations or catastrophic injuries, then improvement in physical function would not be our priority, but instead maybe focus on reduction in pain severity intensity and improvement in function in other domains, such as social or psychological. One tool that can be used to assess movement toward treatment goals with our therapies that we utilize include the PEG score, which allows you to assess pain average, enjoyment of life, and general activity. To summarize, when developing a treatment plan with patients, we should be engaging in shared decision-making in which we're taking into account the patient's concerns and expectations and the biopsychosocial factors that contribute to their pain. We also should recognize what the patient's treatment goals are in terms of functional goals and also what they believe to be a tolerable pain level for them. We should also engage the patient in active participation and ensure they have good education surrounding the risk versus benefits of the various therapies, and also recognize when therapies may be titrated or when they may be tapered or discontinued due to inability to reach treatment goals or due to side effects that are intolerable. So one tool that could be utilized to outline these treatment agreements and treatment plans is a patient-provider treatment agreement. However, to date, there isn't data available that suggests that these are efficacious in reducing misuse and abuse, but they can be a potential avenue for explaining risk mitigation strategies as well as your therapeutic plan. You may incorporate them as a standard of care so that no one is isolated or singled out, and it may include stipulations for patient conduct and outlining patient and provider responsibilities. It could also be used as informed consent, but it shouldn't be used as a tool to fire a patient or have punitive action. It should instead facilitate a conversation between the clinician and the patient and the expectations. Now I would like to provide a brief overview of the non-pharmacological strategies that are outlined in the best practice document from the U.S. Department of Health and Human Services. And we'll begin with restorative therapies. Now, restorative therapies are those therapies that may be provided by physical therapy or occupational therapy, or maybe exercise programs and other physical modalities such as transcutaneous electric nerve stimulation or TENS, massage therapy, traction, thermotherapy such as cold and heat, as well as therapeutic ultrasound and bracing or taping modalities. Behavioral health approaches are a key non-pharmacological component of the biopsychosocial model and serve to improve the overall pain experience and restore function by addressing the cognitive and emotional and behavioral components of chronic pain. And these include a variety of approaches, including behavioral therapy, cognitive behavioral therapy, acceptance and commitment therapy, mindfulness-based stress reduction, and other techniques such as emotional awareness and expression therapy, self-regulatory or psychological approaches. Within this category, I would also include pain self-management programs that are involved in having cognitive and behavioral restructuring and allowing patients to develop the skills for living and coping with pain. And the third group of non-pharmacological therapies that we'll discuss today are the complementary and integrative health therapies. So complementary approaches are essentially those that are not considered mainstream, but are often used together with traditional medicine. And integrative health basically brings conventional and complementary approaches together into multimodal interventions. So if you want to learn more about it, you can visit the United States National Center for Complementary and Integrative Health online. But these therapies include acupuncture, massage and manipulative therapies such as spinal manipulation. There may be some overlap with some behavioral therapies such as mindfulness-based stress reduction, as well as exercise-based forms of complementary and integrative health such as yoga, tai chi, and even spirituality, which is a broad concept, but it gives patients a sense of belonging and connection and potentially greater purpose. And so that could be a potential modality for pain treatment in a biopsychosocial model. In the 2022 CDC guidelines, authors advise that clinicians should maximize the use of non-pharmacological and non-opioid therapies for patients with acute pain. And the modalities that are suggested within the CDC guidelines for acute pain do largely include some of these restorative therapies, such as heat, ice, massage, exercise, transcutaneous electrical nerve stimulation, braces, such as lumbar support or cervical collars, as well as some complementary or integrative health modalities, such as acupuncture, spinal manipulation, and various forms of massage, including acupressure. Consistent with the CDC guidelines, the American College of Physicians, in their discussion of acute low back pain in their guidelines, do recommend that non-pharmacological treatment with superficial heat could be utilized, and massage, acupuncture, spinal manipulation could be considered. In their guidelines for acute pain from non-low back musculoskeletal injuries, the American College of Physicians and the American Academy of Family Physicians make a conditional recommendation to consider a specific type of acupressure to reduce pain and improve function, or using a TENS device to reduce pain. A systematic review from AHRQ published in 2020 provided evidence for non-pharmacological restorative therapies for other forms of acute pain as well. For instance, for acute neck pain with radiculopathy, exercise might be effective, and cervical collar for patients with acute pain with radiculopathy might be effective. Other restorative therapies that may be helpful include massage for postoperative pain and electrical neuromodulation or TENS for acute musculoskeletal pain that is not of the lower back. According to the same systematic review, there is evidence that some complementary therapies might be effective for various forms of acute pain. There was insufficient evidence to evaluate behavioral therapies for acute pain. In their second recommendation, the CDC guidelines from 2022 also suggest that clinicians should maximize the use of non-pharmacological therapies for chronic pain. As recommended by the 2022 CDC guidelines, clinicians should recommend appropriate, non-invasive, non-pharmacological approaches to help manage patients' chronic pain and provide examples such as exercise, physical therapy, weight loss, manual therapies, psychological therapies or cognitive behavioral therapies, mind-body practices, acupuncture, and massage. Given that musculoskeletal pain, particularly of the joints in the back, is the most common type of chronic pain, I reviewed guideline recommendations for non-pharmacological therapies in chronic musculoskeletal pain. Let's begin by looking at restorative therapies. In the guideline for chronic lower back pain, exercise is strongly recommended, as is motor control training, which focuses on restoring control, coordination, and strength of muscles, as well as balance. For chronic lower back pain, manual therapy, particular spinal manipulation, is also strongly recommended. The EULAR guidelines for hand osteoarthritis, motor control training is also strongly recommended, as are certain type of braces for the hand and assistive devices. Now, there are multiple guidelines focused on hand, knee, hip, and polyjoint osteoarthritis with slightly differing recommendations. Let's review those. For the ACR guidelines, exercise and weight management is strongly recommended, as are braces or taping in certain conditions such as of the hand, and assistive devices are strongly recommended, such as a cane, for knee and hip osteoarthritis. Conditional recommendations from the ACR guidelines are thermal therapy with heat and cold, motor control training for knee or hip osteoarthritis. For the remaining osteoarthritis guidelines, you can see that the OAR-SI guidelines strongly recommends a combination of exercise and motor control training in a structured land-based exercise program, and conditionally recommends weight management and assistive devices. In the NICE guidelines for osteoarthritis, exercise and weight management is also strongly recommended, with conditional recommendations for manual therapy, bracing, and assistive devices. The AAOS guidelines for knee osteoarthritis also strongly recommend exercise and weight management, with conditional recommendations for motor control training, manual therapy, massage, TENS, bracing, and assistive devices. The ACR guidelines and the NICE guidelines do not recommend use of the TENS device for osteoarthritis. The ACR guideline also does not recommend manual therapy or massage therapy for osteoarthritis. In terms of non-pharmacological behavioral therapies, Chronic Lower Back Pain Guideline published in 2017 does strongly recommend CBT, mindfulness-based stress reduction, and progressive relaxation. As you can see in the osteoarthritis guidelines published 2018 and after, do strongly recommend primarily self-efficacy or self-management programs, as well as education on the condition, the painful condition. The OAR-SI guidelines do conditionally recommend self-management programs and also have conditional recommendations for CBT. And where these recommendations carry a higher weight is when patients have widespread pain, which then could maybe imply potentially more of those psychosocial factors involved, or patients with depression. Guideline recommendations were also made for complementary therapies for chronic pain. Acupuncture, yoga, and Tai Chi are strongly recommended for chronic lower back pain. Tai Chi and yoga also have strong recommendations for osteoarthritis of the knee and hip. Conditional recommendations exist for acupuncture and yoga and osteoarthritis. And the NICE guideline for osteoarthritis actually suggests do not recommend for acupuncture. A systematic review was also conducted on non-pharmacological therapies for chronic pain by AHRQ and published in 2020, and it demonstrated that the interventions that we just reviewed for chronic musculoskeletal painful conditions improved pain and function and had a durable effect. The outcome looked at was for greater than or equal to 1 month. Fibromyalgia was also investigated in this systematic review, and it was found that restorative therapies such as exercise and myofascial release massage improved outcomes, as well as behavioral therapies such as CBT and mindfulness practices, as well as complementary therapies, Tai Chi and acupuncture, also improved pain and function. Although the non-pharmacological therapies that we discussed can be a part of the treatment plan and may be helpful, the CDC guidelines does make this clarifying point that this does not mean that patients should be required to sequentially fail non-pharmacological therapies before moving on to other therapies that may be beneficial. Thank you for watching this module. I would like to conclude by summarizing our discussion today. Given our current understanding of chronic pain, we should use a biopsychosocial approach to managing and evaluating chronic pain. We should investigate all the factors that influence an individual's pain experience and leverage the tools in our pain management toolkit to address the various factors that influences an individual's pain. These items in our toolkit may vary from individual to individual, and there may not be a particular sequence or combination that is effective for all individuals. It's important to individualize care. But what we should give and offer to all patients is education about their condition, education about the biopsychosocial approach, and encourage them to take an active role in their pain management.